we've all drawn a bad card, and that's not to be morbid, but we all have individual susceptibilities. So some people have, lifestyle, will live the same lifestyle, poor lifestyle factors, but one is going to develop diabetes, one's going to have Alzheimer's, one's going to have autoimmunity. And that trajectory is largely shaped by our individual genomic susceptibilities. And so I think the same thing, this isn't a trigger for everybody. And some individuals have key immune susceptibilities within their genetic response, some genetic vulnerabilities in their immune response, and some don't.
Welcome to Demystifying PANS and PANDAS, the podcast where we uncover the mysteries, breakthroughs, and hope behind these life-altering conditions. I'm Dr. Nancy O'Hara, a board-certified pediatrician, educator, and advocate with over 3 decades of experience helping children and families navigate the challenges of neurodevelopmental and neuropsychiatric conditions, especially PANS and PANDAS. These disorders can feel overwhelming, but here we'll break down the science, explore transformative treatments, and share stories of resilience and recovery. If you've ever wondered what's possible for your child or how to find answers, this is the place to start. Let's dive in. Welcome back, everybody, to Demystifying PANS PANDAS. I'm Dr. Nancy O'Hara, and I really am honored to have Dr. Ari Calhoun with us today, not just because she's originally a fellow West Virginian, but Ari is an amazing naturopathic doctor and founder of Wholesome Brain Medicine that specializes in the treatment and prevention of neurodevelopmental and pediatric neuropsychiatric conditions that includes autism, ADHD, PANS, PANDAS, anxiety, OCD, tics, mood disorders, everything we talk about here. Her work spans a full developmental timeline from preconception, and she is talking about that in our advanced clinical modules at MedMaps. So if you're interested in that, join MAPS, and Ari will be talking about that. But she talks about it through conception, through pregnancy, through childhood and adolescence, with a focus on how the immune system, the metabolic systems, genetic systems, and the environment all shape the brain development and mental health. She's widely known for her nuanced and science-based work in vaccine risk assessment and individual immune support, helping families navigate vaccination decisions while optimizing neurodevelopment and long-term neurologic resilience. So, Ari, thank you so much for being here and for all the work you do.
Oh, thank you. I'm honored to be here.
I listened to Ari talk at one of our recent MAPS conferences on genetics and vaccine sensitivity and how our genetics and our genomics influence individual vaccine decisions. And it was such a thoughtful and well-researched and it was a game changer for me. And I wanted to share the last slide in that talk, I think says so much. And it was just genetic insight, informed immunity. The question is not whether immune activation influences neurodevelopment, but how we choose to honor that knowledge in our timing, our tools, and our trust in our child's biology. And I just thought those words were so profound and so important in the way we frame our discussion around this. I just had to have you on, Ari. So thank you.
Oh, thank you. It's been a passion of mine from the very beginning. I think as it pertains to the preconception, one of the first lectures I ever listened to on autism was related to maternal immune activation and the influence on early brain development. And I was 3 months postpartum at the time. And again, it was the first time I had ever heard that concept of immune system impacting neurodevelopment during this critical window. And at that time, again, I was navigating these vaccine decisions for my own child, my very first child, and wondering, okay, if there's this immune activation in pregnancy that we have a very strong association with, what does that mean as it pertains to immune activation in early childhood, with vaccines being one of the most notable aspects of immune activation that we're kind of intentionally engaging in? And so that's what really started my own research, is just what does this look like for my own child? And as I began to go down that path, realizing, this is information that I know other providers want access to and other patients want access to, and we're all still learning. There's a lot that we don't know.
Yeah.
But, I think along this journey, I've learned that, there are steps that we can take to diminish and individualize this process, diminish risk, I should say, and individualize this process so that we are able to gain access to some of the benefits while not approaching this just purely from a fear-based standpoint.
And I think that's so true and so important because, we know that vaccines induce an immune reaction. That's what they're supposed to do. That's what they're meant for. But in children with underlying issues, sensitivities, genomically or otherwise, you believe vaccines can trigger neuroimmune sensitivities?
Yeah.
And if so, why?
Yeah. So I think, again, going back, vaccines, what are they intended to do? They're intended to create an immune response. And you cannot create antibodies without releasing cytokines and creating this inflammatory response within the body. So we know that. We know that this is why children become fatigued or they get a fever or they get a local response. That's an inflammatory reaction. And so that is very well documented. Certain inflammatory cytokines are going to be released in response to a vaccination. And our vaccines all, engage with the immune system in a slightly different way. And some don't do that naturally as strongly as others. So we need things like aluminum, which is an adjuvant, to further trigger that inflammatory response. And so when you look at this and you look at these cytokines that are, again, known to be released in the state of vaccination, they mimic many of the same cytokines that we think about related to autism or even PANS and PANDAS. And so I talk a lot. I think these are like one of my favorite concepts is the concept of the microglia and the role of the microglia. Obviously, this is a much more complex conversation than that, but I think that is one area that's rather easy to explain and easy to kind of understand, and it's one of the most kind of has the most profound implications on brain development as well as mood regulation. So the microglia are our resident immune cells, and they are going to be, as they're, being immune cells, they're going to be influenced by any type of immune signaling, namely a couple cytokines that are going to be relevant in the state of vaccination. And in the early neurodevelopment period, I like to refer to them as like the early architects of the brain. So they really control neuronal migration and synaptic pruning, kind of like the reorchestration of that brain. And in that ages, from really fetal development through 3 to 5 years of age. They're really central to that neurodevelopment trajectory. And when they become activated, they don't do that job as efficiently as they should. And we can get altered synaptic pruning. And so this is where kind of my interest in autism and those associations come in. And I think for PANS and PANDAS, later on, microglia become a big mood regulator. And obviously, we certainly understand in our PANDAS cases, there's a autoimmune encephalitis component. But I think, and what I find in my PANS cases, is that this can be largely more neuroinflammatory mediated. And we know that these microglia control regulation of two key neurotransmitters that impact mood, being glutamate and dopamine. Again, coming back to this, if we know that microglia are central to the early development, the early architecture of the brain, and they're potent mood regulators, and we know that they're responsive to cytokines that are released in the face of vaccination, I don't think we can not question, is there some sort of potential association here, given that we are given, 57 antigen exposures by 5 years of age. We are, this is one of the most known and established immune activation kind of interventions, or in general, like even if we kind of take that out and not say medical interventions, just as a whole, we get way more vaccinations than we do illnesses in our first year of life. And so it's notable, I think. And certainly, going back to that individual susceptibility, I know we both use genetics in our practice, that not everyone has the same sort of response to an immune trigger. And some individuals are going to have a high release of certain cytokines or have issues with regulating that immune response, be unable to shut off that inflammatory response. And so when we are thinking about triggering an immune response, we want to look at that at an individual level and understand that not everyone's response is going to be the same. Not everyone's going to have this just transient blip in an inflammation and cytokine release. Some, it might be more prolonged. And so that's, I think certainly something that I would love to see more studies on. And I think, and I strongly believe this could be a trigger and a sensitizer to not only things like autism, but potentially kind of long-term neuropsychiatric conditions. Because we see this, I mean, one of the things I'll talk about with my patients is fetal, maternal immune activation. So this inflammatory response in pregnancy isn't only associated with autism, but it's associated with schizophrenia, which happens years down the line. So this isn't just about this acute response, but it's about the sensitization of these microglia. We know that with the microglia, it's not just the first infection or the first vaccination or the first immune trigger that creates this neuroinflammatory response. We're getting signals over time that make those microglia then more sensitive to the final trigger that then creates this more prolonged neuroinflammatory response.
Yeah. So much to unpack there. And everybody that's listening, go ahead, rewind, listen again to the last few minutes, because Ari just gave you such a wealth of information in the last 5 minutes. I really do want you to listen to it again and again. And I think some key points, one of the things you talk about a lot is triggers being different than a cause. And this is one of the triggers when we're talking about neurodevelopmental and neuropsychiatric symptoms. There's no question about that. But why do most children seem to tolerate vaccines well, while a smaller subset may have this immune or neurologic responses? And I think you talked about that a little bit with the genetic variability and the genomic SNPs and all that, but talk about that a little bit more.
Yeah, I mean, I think, again, if what we believe is that these inflammatory triggers should be short-lived, transient. We know we're going to elicit an inflammatory response, but this isn't something that's necessarily going to be prolonged. But there are, again, individuality, and this is why some kids get or PANDAS with strep and then some don't. Or, some kids are prone to autoimmunity. I used to always say, even before I got into genetics, we've all drawn a bad card, and that's not to be morbid, but we all have individual susceptibility. So some people have, will live the same lifestyle, poor lifestyle factors, but one is going to develop diabetes, one's going to have Alzheimer's, one's going to have autoimmunity. And that trajectory is largely shaped by our individual genomic susceptibilities. And so I think the same thing, this isn't a trigger for everybody. And some individuals have key immune susceptibilities within their genetic response, some genetic vulnerabilities in their immune response, and some don't. And so, when it comes to vaccinations, I know there's been a lot of talk about toxins and detox pathways, and not to say that that's not relevant at all, but for me, that's not the pathway that I focus on. I really look at what is the immune response, because we know that that's something that's triggered. I think the relevance of aluminum detox is widely debated, and we could get into that and we could, discuss it. And there's some thoughts I have about that. But I think that the individuals, and what I find in my practice, that are most vulnerable to a vaccine reaction, and this is something that I see more than most because people come to me following a reaction. Yeah. And so individuals that are susceptible to these, vaccine reactions tend to have immune pathway dysfunction. And it is namely in those immune pathways that are triggered in the face of vaccination. So, and I don't actually know, is your podcast, is this mostly clinicians or mostly parents that we're speaking to?
We have both. I mean, I've had a lot of practitioners reach out to me and talk about things we brought up on the podcast, but I know the large majority are very well-informed parents.
Okay, I know. Our parents are so informed.
Aren't they?
So I think that one of the things that I talk about a lot is, again, going back to aluminum. What is its role? We know that aluminum is put in there because it needs to generate a more long-standing immune response. And they found this out very early with the diphtheria vaccination, that without the aluminum, we don't sustain that antibody response. But with the aluminum, it conjures up a more robust immune response that provides more sustained immunity. So this is the whole point of an adjuvant. But that doesn't happen without collateral damage. And so when you add something that stimulates a higher immune response, you're going to get more inflammation. And so that aluminum acts on the NLRP3 inflammasome complex, which is something we study in a wide variety of different inflammatory disorders, not just brain-related disorders, but certainly we look at it in the face of autism and PANS and PANDAS. But it's implicated in, acute respiratory distress syndromes and other things of that nature. But this inflammasome complex releases two key cytokines, interleukin 1 beta and interleukin 18. And interleukin 1 beta is something that we know is a strong microglial activator. And
Yeah.
so we can kind of presume that potentially, if there are genetic vulnerabilities that might kind of allow for someone's inflammasome complex to be activated a little bit more easily or more strongly, or for them to release more of this interleukin 1 beta. I think about this as kind of like dials on a radio station. Some people
Hmm.
have their dial way turned up. And so when they get an like some sort of immune stimulus, their immune response is 10 times greater than
Right.
someone else's. And so again, our intention is to activate an immune response, release some interleukin 1 beta, not release tenfold of this
Right.
interleukin 1 beta. And in those that release tenfold, it's reasonable to say that could be a problem, and that could create a response that's undesirable. And we know this even in the face of, febrile seizures. That's something that is a kind of a well-known side effect of some of our vaccinations. And that's one of the cytokines that's implicated in that is interleukin 1 beta. Now, not everyone who has a vaccination is going to get a febrile seizure, but
Right.
some are going to be more prone to that. And so I think about this as like, we just want to look, if we have the opportunity to, not always do we have the opportunity. And for years I operated without genetics, but now that
Right.
we have genetics, I think it's a really cool tool to look at who might be susceptible, who has their knob turned up, this dial turned up, where they're releasing more of these key cytokines that could be relevant in the face of brain inflammation or other things. We could look at atopic conditions or autoimmune conditions, but as our field, we're very attuned to this neuroinflammatory response is one of the things that parents are most concerned about as they face these vaccine decisions.
Right. And just taking it back a minute for those
Yeah.
parents who don't really understand this, what we're really talking about are SNPs, single nucleotide
Mhm.
polymorphisms, small pieces of genes that impact our susceptibility, our ability to handle different things, whether it be an infection like strep,
Mhm.
or aluminum in a vaccine or a live viral vaccine or mycoplasma or a tick-borne disease or
Mhm.
whatever it may be. And so you've talked about those SNPs with microglial activation, that
Mhm.
inflammasome complex, the
Mhm.
NLRP3 and CARD8 and others. The
Mhm.
other one I really love what you call it, which is the Trojan horse, the
Mhm.
CCL2.
Yeah.
Can you just talk a little bit about
Yeah.
that one?
Of course. So yes, we can have, as you mentioned, like my primary interest is what are the cytokines that could create this microglial activation, which are NLRP3, CARD8, control the inflammasome complex, interleukin 1 beta, interleukin 6, TNF alpha. And then we can go on. And the CCL2 is another SNP that I actually think we have a lot of evidence on in terms of
Yeah.
its potential implication in an adverse response to aluminum adjuvants in particular. So CCL2 is essentially controls a chemokine. So it's a signaling molecule that kind of directs certain immune cells to a site of injury or a site of inflammation. And so it is something that can amplify an inflammatory response because it can kind of bring immune cells in. But the other important role that has been identified is that it's potentially implicated in increased persistence of aluminum.
Hmm.
And so when CCL2 signaling is higher, result is that we bring in more of these immune cells, and some of those immune cells being these immune cells called macrophages. And when I was in medical school, I remember my immunology teacher talking about them as little Pac-Man cells, which I just think is a great
Oh,
analogy.
that's
And so
great.
they come in and they eat up a lot of different cellular debris. But in this process, if we're talking about it pertaining to a vaccination, if we're giving an aluminum containing vaccination, what we also know is that they start to consume this aluminum. And then what has always been, when I was first looking into vaccinations, aluminum has been widely debated for a while. And all the pharmacokinetic studies have said that aluminum is rapidly metabolized by the kidneys. Like we just don't see it in the body for a prolonged period of time, which is largely true for the aluminum that gets into the bloodstream. It's
Right.
not something like aluminum behaves very differently than other heavy metals. And it's always been an interesting one to kind of study. We don't know as much about it as we do lead and mercury and how to get rid of it and what to do about it. But what was left out of a lot of these pharmacokinetic studies was the fact that not all aluminum makes it into the bloodstream. Some of it gets engulfed by these macrophages, and these macrophages don't have a way to just break down. They don't just they're not just eliminated by our body. And so these macrophages can retain the aluminum and then start to travel to distant sites dependent on that CCL2 signaling. So again, if there's inflammation in a different area of the body, it might pull them to that particular area of the body. And this retained aluminum has been implicated in other conditions like macrophagic, I'm going to butcher the name right now. It's macrophagic myofasciitis is the name, where these aluminum particles driven by CCL2 signaling get retained in muscle tissue and cause long-term inflammation in the muscle.
Wow.
Now,
Yeah.
in animal studies, it has been shown that these related to the CCL2 signaling, so again, CCL2 is kind of like a driver of these macrophages, can drive this aluminum or these macrophages and these aluminum-laden particles to different regions, so to different organs and even the brain. So the consideration here is if we know that we have excess CCL2 signaling and we assume that we have excess macrophage infiltration, we get excess aluminum phagocytosis, and now we have these immune cells that are carrying around this heavy metal and they're traveling dependent on where that signaling is, it's plausible that if we have this ongoing neuroinflammatory response, that they're going to be trafficked to the brain because aluminum just can't pass the blood-brain barrier. It needs something to carry it in there. And so this is the Trojan horse mechanism whereby these macrophages get transported into the brain to do something helpful for the brain, but now they're carrying kind of a particle that creates oxidative stress and potential harm to the brain. Now, again, we need more data on this. We're still in the very beginning of understanding this, but we see it in animal models. And I think, we certainly have seen it in other types of neuroinflammatory conditions, such as Alzheimer's, where we know that higher aluminum is in the brain is associated with neurodegenerative conditions. So I think it's plausible and needs, further research, and we need to look into it. But I certainly find that to be relevant. And I know that you've looked at CCL2 even as it pertains to PANS and PANDAS and weakening of the blood-brain barrier and how that could potentially impact antibody transport and others. But I think, as it pertains to the aluminum piece, it's pretty clear that could increase biopersistence of this heavy metal that would otherwise be very quickly eliminated.
Right. And I think that's such a key point that so many people don't understand. So again, go back, rewind, and listen again, because it just
it's complex. It is
complex, but it's important to understand and not be fear-based. When you can understand these mechanisms a little bit more, even just a little bit, even if you just take one pearl from the last 20 minutes, as a parent, you can start to understand how these things may be triggers in a susceptible child and may be looked at somewhat differently and understood better than just, vax, anti-vax,
Well, and that's what I love, right? Because I'm in, California, so we have very strict requirements. If you want your child to go to school, despite your concerns or history of neurodevelopment challenges, PANS, PANDAS, I have a lot of my parents that grapple through this and even if they don't feel super comfortable, they have to kind of proceed with certain vaccinations. And in the face of that, I think knowing these susceptibilities, but even outside of that, even if we don't have the funds to put this into genetic testing or someone to interpret it appropriately, there are certain steps that we can take to modulate that immune response, to diminish some of that CCL2 signaling, to diminish some of this release of interleukin-1 beta or kind of calm those inflammasome complex. So again, outside of having that information, there's still a lot of supplemental interventions or ways that we can kind of arrange the schedule to diminish the kind of the impact of some of these vaccines, the inflammatory signaling from these vaccinations. And that's what I focus on in my population is, okay, in the face of this vaccine, what can we do to kind of settle this immune response, regulate it, so we're less susceptible to some of these secondary, conditions that we're worried about?
Exactly. And I want to get to the mitigation part in a minute, but let's step back a little bit because I want to talk about factors like timing and immune load overall
Sure.
and environmental stressors that influence whether
hmm
symptoms can emerge. So talk a little bit about that, because I think those are important keys too.
Yeah, 100%. So again, going back to this idea of the microglia, just because I think it's the simplest one to kind of understand, this isn't a one hit hypothesis. So even when we know, okay, maternal immune activation, which is inflammation in pregnancy, has a strong association with autism in the offspring, or again, prolonged or other mental health conditions. Schizophrenia is most kind of notable in terms of its being named, but PANS and PANDAS has never been studied, right? So we don't know if there's some sort of association there, but we can say, some sort of immune activation in pregnancy can be a factor. And in functional medicine, we oftentimes refer to this as like antecedents versus trigger. So antecedents
Right.
would be things that kind of create susceptibility in the body. And then the trigger is the thing that kind of initiates the symptoms, right? So
Right.
in terms of antecedents, we know obviously things that in pregnancy occur that create an inflammation would make me more concerned that there could be susceptibility for a child. So take genetics out of this. When I'm looking at with my vaccine consults, which I've been doing this for a long time, again, prior to me having access to genetics, we'd be looking at what happened in pregnancy. Does mom have an autoimmune condition? Did mom encounter some sort of serious illness, right? So we're not talking about the general colds, but a
Right.
prolonged fever. Did you need to take anything for a fever reducer? Were you hospitalized from this? Does mom have metabolic conditions that could be raising inflammatory cytokines, which is something that I think we don't talk about enough? So gestational diabetes, obesity, preeclampsia, that's certainly an inflammatory condition. Even certain stress situations, which is
Yeah.
kind of harder to know, like which part of this created enough of an inflammatory response. But they've found associations, even like 9/11 or certain tornadoes or storms in certain regions of the world, that's created enough of a stress response where it's created this inflammatory cytokine response in moms. And so we're looking at things that would sensitize these microglia. And then we're looking, okay, early childhood sensitization. So prematurity, any sort of birth trauma, impaired oxygenation at birth. Obviously, we know that those are all inflammatory triggers. Did mom get a fever during pregnancy or during delivery, which can
Right.
happen? And not it's not super rare. It's up to 10% of women can have a
Hmm.
fever response. And then we're looking at, okay, was there mold? We know that mold is a huge factor. What does the microbiome look like? So was the baby C-section versus breastfed? We know that the microbiome, I think about this when I work with my patients. There are these foundational aspects that kind of just raise that inflammatory threshold closer to that point where some sort of trigger could put us over the edge. And
Right.
so we want to think about all of these foundational aspects that create what's our background level of inflammation.
Right.
And the
And part
gut
of our
is a
total load.
total load,
Yeah.
absolutely. So the gut is a huge one, right? So I'm looking at the state of the gut microbiome. Do we have a really healthy bifidobacteria population and, very few pathogenic organisms? Or are we really struggling there and we have a bunch of pathogenic organisms and really depleted bifidobacterium? That is really crucial to how we're going to respond to some sort of immune stimulus. And so that kind of goes into my, what's the background of the immune state? And again, even without genetics, you can do a little bit of investigation into family history. So do
Right.
we have a family history of any sort of autoimmune conditions, atopic conditions, which is a little bit separate than, creates some additional triggers outside of neuroinflammatory triggers, but atopic conditions like allergies, eczema, asthma, very relevant when it comes to the aluminum containing vaccinations. And then I actually lump in neuropsychiatric conditions into this potential susceptibility for an inflammatory response because
Yeah.
my feeling as I've been working, and this is just anxiety, depression, ADHD, behavioral issues, is that the vast majority of these have a inflammatory component. Even if it's not the
Absolutely.
central component, it's part of that susceptibility and part of that symptom aggravation for many.
Right. And I think that's so important, when we're talking about PANS and PANDAS, the P is pediatric and it should be abrupt onset, but there's so much more than that that can cause inflammation within the brain, autoimmune
Mhm.
encephalitis, the immune system working against self to cause inflammation in the brain that affects this whole spectrum of what we call neuropsychiatric issues,
Mhm.
anxiety, OCD. So whether the definite it fits the definition of PANS PANDAS. All of these conditions fit in that sort of neuroencephalitis, neuroimmune picture. Yeah.
100%.
Yeah.
And so I'm sure you go through this with your patient population all the time. There's certain things where it's like, what doesn't meet criteria perfectly? Like there wasn't this
Yeah.
abrupt onset, or you don't have OCD, restrictive eating behavior, or tick, but there's clearly an immune trigger. And I find that so often. And that's where it comes back to me. Mechanistically, I like to separate these. Is it an autoimmune encephalitis or is it more broad spectrum neuroinflammation? And
Right.
there are going to be overlapping treatments, but there's also going to be some key differentiators in terms of like who's going to be responsive to some of these things like IVIG versus who's going to be more responsive to our anti-inflammatories, who's going to be more mast cell mediated versus who's going to, be a little bit different. So I think I find right now, and you might as well, there's a lot of interest in PANS and PANDAS. And there are a lot of families that are coming to say, like, intuitively, this is inflammatory mediated. We see these ebbs and these flows, but we can't get a diagnosis and no one's going to no one's treating us because it doesn't fit in the box. And yet, when we actually do that kind of underlying investigation and support treatment, a lot of times it still sits in the immune bucket.
Right.
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 So immune treatments still have impact.
Absolutely. And I think that's part of functional, integrative, root cause medicine versus conventional medicine. In conventional medicine, it's black or white. It's either
Mhm.
PANDAS or it's not.
Mhm.
No, there's all this gray.
Mhm.
There are a lot of kids that have immune activation, that have neuroimmune issues that
Right.
may not fit the strict criteria of PANDAS, but that doesn't mean the immune modulating interventions and the
I'm not gonna be helpful.
preventions and all that aren't going to work. So,
Mhm.
so important. And I
Mhm.
think, you talk about timing, you talk about the
Oh,
the
yeah.
history that you're
Yeah.
getting. It's also the
So
the time of year. The
right.
immune load, like if a child has a vaccine that may be more elective, it doesn't
Mhm.
have to be given today.
Yeah.
Looking at what time of year you give it, what the rest of the immune system may be exposed to that you may want to treat before you give the vaccine.
Yeah.
You want to
So,
address that a little bit?
yeah, I think that that's really important. I think, one of the things that I will say, and I've said for a long, and now things are shifting a little bit with the new administration in terms of how we have this conversation, but the CDC schedule, it was created from a public health measure, right? So that's
Right.
important for us to understand. So the goal of this intervention is to decrease these kind of disease rates as a whole. And it's been effective at doing that, right?
Right.
And the secondary kind of intention is to protect the most vulnerable. And so it's doing that. But what it ignores, and it doesn't necessarily, it's not its primary intention, is to protect the individual. Not to say that that's not part of their, intention, but it's not the primary intention.
Right.
And it's not the primary thing that's measured. And so I really take this back, and not to me, there shouldn't be any sort of blanket treatment that we do across the board. This is, why we came into functional medicine, is because we're not interested in an algorithm and a protocol, but we want to look at the individual and figure out what's best for that person in our office. And so vaccines should be no different than any other intervention. And so
Right.
when we sit down and we do this kind of vaccine analysis, there's always going to be a pro and a con, right? This is never a black and white situation. I'm sorry, it's not. And people that make it into that are either they're ignoring a potential benefit or, again, a potential risk. It's
Right.
always a black and white, and we don't have a crystal ball. I always tell my parents, like, if we had a crystal ball and we knew your child was going to be exposed to this particular illness, yes, the vaccine is the better choice, but we don't always know that. So sometimes it's worth kind of looking at rates, looking at susceptibility based on other factors. So I think when it comes to the vaccines, the first conversation I have is, what are the illnesses that we're trying to protect against? Because that's
Right.
not talked about. It's just like, this is what we do at 2 months. This is what we do at 4 months. This is what we do at 6 months. And we just kind of go along with that, but we don't understand like exactly what this is offering to my child. Like, what is this protecting them against? So that has to be part of the conversation. And then we can make choices from there. Are you susceptible to this particular illness? And if so, what would be the treatment for this if you were to get this? How do we test for this? What are the symptoms of this? How severe might this be? And then what are the potential side effects of that particular vaccine, and we can kind of weigh those. Do we want to utilize a vaccine from a prevention standpoint, or do we want to kind of try to cocoon or avoid or boost up our immune system in other ways, and then take our chances and then know what to do in the event that we were to come in contact or our child was to get this particular infection. And that has to be a choice by the parent. Like, there is no
Right.
provider that should be making this choice. The parent has to make that choice. And they just deserve full informed consent. They need to know the risks and the benefits, right, of every intervention and every illness. So that's where we start this conversation. So in early childhood, we can whittle this down a little bit in terms of not everything that's on the standard schedule is going to have that same level of priority. And it's also going to differ greatly and dependent on, are you putting your child in daycare, or are they going to be at home with a single caregiver? Do they have older siblings? Do they have other health complications? I spoke with a mom earlier this week, and her child was potentially going to go in for a liver transplant. Well, that's very different, right? So
Yeah.
she might have hesitations, but he's also someone who's going to be on immunosuppressant drugs for the rest of his life. That's a very different scenario. So we have to weigh this kind of individually. And also, I always say to my parents, I could have two sets of families that have this very same risk factors, but one might choose to be more vaccine heavy, and one might choose not to do any vaccines. And that's based on their own level of risk aversion and how comfortable they feel with dealing with the possibility that their child could get one of these illnesses, and understanding how to kind of appropriately care for their child in that situation. These are things that, again, it comes down to the parent has to make the decision. But our goal is to have full informed consent and offer some feedback and true kind of risk management. Not all vaccines are perfect. That's another thing that we have this kind of misillusion about. We have this idea that if we give a vaccine, we have this golden shield around us that our child will never come in contact or never get pertussis. If they have their 5 series of pertussis vaccines, they're just never going to get pertussis. And we know that that's not true. So what is the vaccine actually offering? And does that benefit to me give me more peace than the potential fear that I have for my child having a reaction? And so that's what we're talking about. I think as it pertains to, illness and infections, there are some things that I think about just more globally, like a live viral vaccine really requires an appropriate immune response to keep that antigen from replicating.
Yep.
We are going to see more side effects if a child has some immune suppression. And this is why we don't give a live viral vaccine to a child who has an immune insufficiency, because they're more prone to the secondary effects, essentially the symptoms of the illness itself.
Right.
So in the same light, I don't like to give live viral vaccines, particularly something like MMR, when we're in the midst of cold and flu season, if I can avoid it, because we have no idea if you're going to encounter RSV next week or influenza next week. And if your body's trying to deal with these 3 viruses it's just been given, and bam, you get hit with influenza and RSV at the same time, well, that's a very different risk profile. So there are some things in that nature where if we're going to time vaccines, I try to time the live viral ones, during a period of the year where we're not as likely to encounter secondary infections. And then again, I think as a whole, if we're just thinking about, the developing brain, that first 3 years is critical for our neurodevelopment trajectory. And I relate this back to anesthesia. We have this really well-known association where anesthesia under 3 years of age has a much, higher likelihood of impacting long-term neurodevelopment outcomes versus anesthesia after 3 years of age, even for the same duration. And so again, it's just kind of this, if our if our brain is impacted for a chunk of time, it's going to have more significant outcomes if that chunk of time the brain is developing at a much faster and expansive rate, right? So we don't want to miss out on a month of our child's development because they're dealing with a neuroinflammatory response when they're under 3. After 3, it's different. It's not going to have that same long-term impacts typically. So it doesn't mean that we don't vaccinate under 3, but it does mean that we're going to take that time period a lot more seriously and look at it a lot more critically than if we have a 5-year-old who's catching up on vaccines. I'm not as worried about that creating some sort of long-term neurodevelopment harm.
Right. And I think it's also important. The other factor is I always get asked, well, grandpa is very susceptible and I want to vaccinate my child to protect my father. Can you address,
Yeah.
people lump all that together and just
Sure.
address that a little bit too.
Yeah, I think it depends on the vaccine, right? So
Yeah,
that's
exactly.
a very good argument if we're talking about measles, right? But grandpa probably has had measles and has very strong immunity to measles. But it's not a strong argument if we're talking about some of our other vaccinations that are not preventing transmission. So we
Right.
could go through a ton of those, like Hib and strep pneumonia, the PCV vaccine, and DTaP are not preventing transmission of this illness. And so their goal is to protect the individual and decrease symptoms. And so I think herd immunity has a role for some vaccines. Obviously, we see now that we are dealing with more measles outbreaks. One of the things that I used to say is, the really nice thing especially still in California, is we have really good herd immunity. So for our susceptible, they're relatively protected. And this
Yeah.
is one where it used to be, and I might come back to this, but it used to be a little bit where we could just operate in this like avoidance of the trigger, right? We have enough of this herd immunity that it's very low likelihood that you would get exposed. So if you hear of a particular infection in your area, cocoon for maybe 2 weeks, kind of like stay low. Don't go to the most popular parks or the most popular museums. And I think that's becoming a little bit more difficult depending on where you live and where that herd immunity is. So I don't want to discount the role of herd immunity altogether. I still think it has a place in the conversation for certain vaccinations, such as the MMR vaccine for measles and maybe rubella, not so much for mumps because it's not a great
Right.
one for mumps. But for other vaccines, we know that it is not preventing transmission. So over 80% of our cases of pertussis each year are kids that have had the vaccination. So we know that potentially they're less likely to transmit it because they're less symptomatic. So that does work. But obviously COVID was a big kind of game changer in terms of this conversation. We know that these vaccines are not all, providing the herd immunity that
Right.
we once thought or kind of it had been communicated.
Right. And I think all of those factors are so important. What's the child's susceptibility? What's the child's environment? What's the child's age? And what's the vaccine? Because we tend to lump everything together and just talk about vaccines. Well, there are many, many different ones. And unfortunately, our kids are getting 57 of them. We need to understand each individual piece. And as somebody
Mhm.
who did their master's in public health, I understand the
Oh,
public
you
health.
did.
I did. I understand the public health perspective. I
100%.
understand what we're trying to do. But as an individual provider taking care of some of the most vulnerable of our children,
Right.
we have to look at their individual vulnerabilities,
Mhm.
their family vulnerabilities, and then what makes the most sense. So
Mhm.
you talk also a lot about practical strategies to mitigate potential neuroimmune
Mhm.
impacts in these vulnerable interventions while still
Mhm.
supporting immune health. So
Mhm.
what are those? What do you talk about when you talk
Yeah.
about
So,
that?
this is sometimes kind of frustrating because it's from a podcast standpoint, it's like dosing and which ones to use.
Nah,
But generally
just
speaking, a
general.
lot of our anti-inflammatories are going to be helpful in forming a more kind of responsible immune response. So a basic one that you can give to babies is omegas, right? So we know that omegas are going to help to regulate that NLRP3 inflammasome complex, decrease that interleukin 1 beta release, dampen a number of different cytokine releases. So omegas are not immunosuppressive. It's not like we're giving them steroids or NSAIDs that's going to diminish the potential benefits of a vaccination and generation of antibodies. But we do see that this can offset some of that extreme inflammatory response. So that one is something that I obviously love to give. There are other things in that realm. So for those that have that CCL2 signaling, then I focus a lot on palmitil ethanolamide, which is one that we see decreasing that activation of the microglia, but also down-regulating that kind of CCL2 activity so we don't give it as much of that macrophage infiltration. It's all around so beneficial for lots of different things, but I think for those CCL2 cases, I really love it. Same with luteolin. Luteolin is an herb that can, decrease things like IL-6, but also some of that CCL2 signaling. I use sulforaphane a lot because a lot
Yeah.
of, especially within the live viral vaccines, this inflammatory response is initiated through the kind of NF-kappa beta signaling. And so sulforaphane, which comes from broccoli sprouts, is wonderful. I mean, almost, you know this, like every single cytokine has some sort of response from something like sulforaphane. And this is a food. If you didn't want to do a supplement, you could do it through broccoli sprouts, which is wonderful. And so that not only has this anti-inflammatory signaling, but it also upregulates the production of glutathione. I do use glutathione with my vaccinations. And this is kind of a more, secondary effect. But anytime we get this kind of inflammatory response, we can see oxidative stress. And so we want to dampen that oxidative stress. And we know that low glutathione has been associated with autism. And so, adding a little bit of glutathione in the mix can be helpful and potentially relevant in the case of aluminum as well. And so those are, some of the key things that I focus on. And then just regular kind of fatty or fat-soluble nutrients that are really important for that immune regulation.
Right.
So vitamin D, we know is like the importance of vitamin D. So ensuring that the child is on vitamin D. And then vitamin A, especially as it pertains to these live viral vaccines, and especially with the MMR, because we know the association between replication of measles, mumps, and rubella in the face of vitamin A deficiency. So we just want to make sure that the child is not deficient there. So those are the things, we use nutrients essentially. And some families, feel more comfortable loading their kids up. Some don't feel as comfortable. And I always come back to even outside of the supplements, there's a lot you can do just with schedule modification. So we can take this and spread this out so we're not giving multiple aluminum containing vaccines at once. We can choose certain brands that have lower levels of aluminum or lower additional ingredients like polysorbate 80 that can influence the immune system, or neomycin, certain antibiotics. So we can kind of look at vaccine brands and choose better vaccine brands. And one thing I just will say as it pertains to kind of like doing this yourself, the one error I see when parents come in with their vaccine schedule that they've created is that they'll spread it out, but they're going back to get a vaccine like every 2 weeks. And that is something that I do try to avoid at all costs. I would rather see someone do 2 vaccines at once or even 3 vaccines at once than be getting a vaccine every 2 weeks. Because then what happens is we never get full immune resolution. We're vaccinating right at the tail end of that immune response starting to kind of settle down. And so we get the sustained immune activation.
Right.
So my general rule is I like to separate vaccinations by at least 6 weeks so we can hit full resolution before we activate an immune response again. And again, sometimes we'll make adjustments to that rule depending on, is the child going into daycare at 3 months and they need certain number of vaccinations. But by and large, at least 6 weeks, trying to spread out these aluminum containing vaccinations, taking some of these aluminum containing vaccinations that may not be as relevant during this early infancy time and pushing those off until later on, and then choosing brands that have overall kind of lower levels of aluminum or some other ingredients that could be further activating to the immune response.
And I know people are feeling right about now, oh my God, I'm overwhelmed. I can't.
I know, yeah.
But it's about being informed and being with someone as a practitioner who will listen, who will see the individuality of your child, and who will help provide a framework for you where we can move away from fear, but also toward an individualized, informed decision-making process. And I just so hear that in every word that comes out of your mouth. And I think that framework is so important for families in moving forward.
Yeah. And the one thing I will say, I think that providers, your standard pediatrician, is much more willing to engage in this conversation if you come in informed than if we come in and our defenses are up and we're unwilling to engage in a conversation, right? So I always share with my patients that, again, if we just change a little bit of our terminology and we talk about immune activation versus toxicity, that's something that even that alone can kind of like allow for a conversation to happen where it may not have otherwise. And so that to me is helpful. And your pediatrician, even if they don't know all of this, they could certainly at least say there are certain vaccines that are truly more relevant than others. Or, I've had this even in PANS and PANDAS where it's like, okay, we want to give the, PCV vaccine to be able to then justify IVIG. And the kid's in the midst of a flare. And I push back on it a little bit and say, But yeah, not to say that it couldn't help justify, but we have enough evidence to at least pursue this first before we go through with a vaccination to, some sort of immune stimulus. So there's ways to, again, just kind of have this conversation, and where information, even if you don't have all the tools and all the knowledge, a little bit can help provide a more productive conversation with a provider, even if they're not aware of, every single aspect of vaccinations or every single possible pathway that might be triggered. They understand this is an immune stimulus. They understand that there's inflammation, and they understand which vaccines are going to be more relevant, that they should
Right.
have a good grasp on.
And everybody can't be as well informed as Dr. Ari Calhoun, but,
I'm
making
learning.
it topical, right, and talkable. And I think that's one of the things that I try to help so many of our families do. Just try to have a conversation. Just try to open your mind to different ways of thinking about things. And again, it's choosing to honor the knowledge of the timing, the tools, the trusting in our child's biology that we started this conversation with, that I think is so important. Ari, I could talk to you for hours, but if somebody wants to get in touch with you or wants to learn more, how would they do that?
Sure. So I run Wholesome Brain Medicine, so you can visit wholesomebrainmedicine.com if you wanted a individual consultation or further information there. I also have a program that I run alongside a colleague of mine called the Vaccine Empowerment Program. And so that's another route that, even if, obviously this is still requires a patient-provider relationship, and eventually you're going to have to go back to your pediatrician or your primary care provider. But it allows you to have all of this background information on each and every vaccination, and even sort of our thoughts as it pertains to neurodevelopment conditions and such, brands, pre and post support. So that's a great resource for those that want additional support in this area and, can't necessarily access an individualized consultation.
That's great. And I love that. And I love your website, by the way, the Amazon favorites. I love that. There's so many good little things in there. And Ari, you're such a wealth of information and experience and talking about this in a way, for me, that's understandable. And I hope for many of our listeners, just reframe things a little bit.
Yeah.
Do you have any last words of wisdom or hope or anything you want to leave families?
I think that I just so strongly believe that there's a way to navigate these decisions without it being from a place of fear. And I find that many parents they just want to be heard, and they want their concerns to be acknowledged. And from a provider standpoint, I think not speaking and listening goes a long way. And just that acknowledgement that their concerns are valid. That is super important if we're standing in the conventional medicine side. Because if we're going to make any movement on this conversation, we have to acknowledge that there are two sides to this. And then from the other piece of this, again, as a California provider and as someone who has my PANS and PANDAS patients have to be vaccinated. My autism patients, by and large, there's a little bit of a loophole there, but have to be vaccinated. There are ways that I've gained a lot of confidence in proceeding with protection and utilizing these vaccines for benefit without it necessarily triggering a regression or further aggravation in their symptoms. And it's always a lot more, we handhold them a little bit tighter and we utilize a little bit extra support. And there's certainly a little bit more nerves going into this, and that's understandable. But I guess from my perspective, I've gained a lot of confidence in how to approach this in a way where the immune system can tolerate these vaccines. So I just come into this believing that it does not have to be an all or none. And if you have options, amazing. If you don't, and you know that you have to get these vaccines and you have apprehension because your child has a neurodevelopment condition or they have this neuroinflammatory response, just know that there are tools out there that can help them go through this process without a substantial flare. Right. And I believe that.
Yeah. And trust Ari, because she knows what she's talking about. But I really appreciate all of your wisdom and the hope you give families to make this talkable and make it something that we can help our kids to not be further injured but to be able to live freely and without fear and with
Mhm.
hope. So
Mhm.
thank you.
Yeah, thank you for having me.
Really appreciate it. And we'll see you next time on Demystifying PANS
Mm.
Pandas. That's it for today's episode of Demystifying PANS Pandas. I hope you're walking away with insights, tools, and hope to help you and your child on this journey. If you found today's conversation valuable, be sure to subscribe so you never miss an episode. Share this podcast with anyone who might need it. It could be the lifeline they're searching for. And if you have a moment, leaving a review helps us reach even more families who deserve answers. Also, for more information, training, and community, check out our website, drohara.com, and join our annual membership. And remember, every step forward, no matter how small, brings us closer to healing and understanding. Until next time, be present, be hopeful, and we look forward to seeing you next time on Demystifying PANS Pandas.